Hi everyone, this is Howard Mann. I'm standing in for Jeff Caney this week. Brent at Emory is going to start us off this week, so I'm going to give him the screen.
Banana seals. Individualized lungs.
Okay.
Good, we can see the screen.
Okay, so I'm going to show a few cases, a couple cases this week. This is a patient whose CT I'm showing. Let me blow this up a bit. Who just has kind of a fairly common phenomenon we're finding, but also just a novelty. You may think I'm showing you a case of tuberculosis, but I'm not. You see a lot of low attenuation mediastinal and hilar adenopathy. There's some enhancement of these lymph nodes. You notice that here in the left lower lobe, there's a wedge resection site where some nodules were removed, and I'm going to change to lung windows here. So you can see that there are some nodules here that had grown over time, and more nodules. This is a patient who had renal cell carcinoma that was invading into the renal vein. And you can see here that the nodules are not truly random. They're somewhat clustered here. Multiple areas of clustered nodules beating along vessels. And you can go down here and see more of that phenomenon where the vessels are expanded with pulmonary arterioles with beating around them. And this is presumably intravascular metastatic spread, as the pattern of many of these clusters of nodules. And then as you go up to the right lung apex, you see this reverse atoll or reverse halo or atoll sign. And presumably this is from one of the metastases that had occluded the artery, the arterial, and had caused an infarct here. So it's kind of one of the few times I've seen this phenomenon before, but it's just an interesting case of a wedge-shaped ground glass opacity with peripheral consolidation here, and atoll sign being caused presumably by one of these intravascular metastases in the setting of renal cell carcinoma. So we're finding these, I don't know what other people's experience has been, but we have just tons and tons of cases of intravascular metastatic disease, especially, and of course the most common malignancy caused that is renal cell, and we've seen multiple ones in hepatocellular carcinoma as well. So,
yeah, very nice demonstration of that.
And this is just more of a novelty. This is one that Arthur Stillman showed me the other day, and this is let me make sure I'm showing the right screen here. Yes. Okay, this is more of a novelty than anything else, and also very important in the sense that this is a pre-TAVI planning CT. We do a lot of these, and as you scroll down, you see the thickened aortic valve with calcification, of course, but you also see a stent, and this is a right coronary artery stent, and of course the abnormal thing about this, it's protruding into the lumen of the aortic root. So imagine why that's important in this case. The transcatheter valve would be sitting right there, and one can only imagine what that would cause if that valve were to be expanded, on that stent. So I don't know if other people have seen a stent. I can't remember seeing a stent that's protruding into the lumen so much. This was not, I don't believe the stent was placed here, but elsewhere, of course. And you can see that it's protruding into the root here. So,
what will they do about that?
Well, not do a TAVI, presumably. So I'm not sure. Dr. Stillman is telling me that they can actually cut this stent. So, I haven't gotten any follow-up on this yet, but presumably they can snip that to smooth that down and actually go ahead and do the TAVI. So, but just don't think I've seen an osteal stent protruding into the lumen that much.
That is curious.
So just a curiosity or an important point. And let me show one other one. Let me pick the, okay, here's the oldest CT we have on this patient. Let me make sure I'm showing the right page here. I believe I am. This is a patient in her 70s who has chronic shortness of breath and had a CT here. And I'm showing you a pattern of diffuse bronchial thickening and mosaic attenuation that's quite noticeable even on this inspiratory CT. And you can see that not only are those things going on, but you can also see that there is fairly diffuse tree and bud nodularity throughout the entire lungs. And you can see the low attenuation areas correspond to areas of air trapping, presumably. I'm going to withhold the history for a second. I'll show you a follow-up CT that was done. I'll show you the NIFs too in a second. Here's a follow-up CT that was done 2 years later. You can see that there's been some progression of this process with areas of air trapping, mosaic attenuation, a lot of extensive tree and bud nodularity, bronchial thickening. And so this patient had a long-term, multiple decades of exposure to cooking wood burning stoves in the setting of cooking. So presumably this is a little bit like the cases of synthetic marijuana-induced combination bronchiolitis organizing pneumonia, in the sense that it has well-defined tree and bud nodules and a lot of air trapping and bronchial thickening. So probably is a combination of, we don't have pathologic confirmation, but sort of a bong boot type appearance, without the marijuana exposure, of course, but from wood burning stoves causing us bronchiolitis obliterans, organizing pneumonia pattern. So
this is from living in the country or something like that, or did she run a barbecue place or something like that?
Well, I don't think of a restaurant, but just in the home, was into, for whatever reason, wood burning stoves and cooking, and had a lot of fume exposure, smoke exposure in that setting. So, and this case is from.
Could some of this bronchial wall thickening and tree and bud business be due to just some underlying RB from that exposure?
The cases, certainly that could be the case. The cases of RB that I've been, pardon the pun, but exposed to in the past have had more subtle central lobular ground glass nodules rather than well-defined nodules like this. And the ones that we've seen that have been so well-defined, as in this case, have turned out to be cases really of, boop, on pathology, the cases that we have. So, but very well-defined, solid sort of, branching, solid central lobular nodules here. So. But anyway, I think those are my few cases this week. So.
Thank you.
All right, sure. David and I think Seth, you're both on. Do you have cases you'd like to show, and who would like to go first?
Dave can go first.
Okay, let me pull up one here. Okay, I'm ready to go. If you anoint me.
I do.
Okay. So they can see you scream. Oh no, it's show my screen, not see you scream. Okay, this is a person with basal predominant emphysema here on a chest radiograph, and then on CT, emphysema is really throughout. You can see there's an upper lobe component here. There's a little bit of attempted saber sheathness to the trachea here, but the emphysema is worse in the bases down here. The vessels are all spread out, and it's looking hypovascular down there. So basal predominant emphysema, we think first of alpha-1 antitrypsin deficiency, but just being Seattle, the other condition here is Ritalin tablet injection, and that was the history in this person here. So we have this basal predominant alpha-1-like emphysema caused by shooting up Ritalin tablets, and this basal predominant emphysema is probably the result of deposition of talc in the lung, and then macrophages trying to clear that talc and spilling their enzymes when they try to digest this undigestible stuff. And that those enzymes basically, including elastases, are breaking down the lung tissue, and that's how you get Ritalin-induced basal predominant emphysema. It's basal predominant because that's where the blood flow carries the talc and carries the macrophages that are going to try to gobble it up and remove it. So basal predominant emphysema, this street name for this drug used to be Seattle. Now there are a lot more potent amphetamines out there than Ritalin, so people don't bother so much with Ritalin tablets anymore. But injecting them used to be a cause of basal predominant emphysema here. Okay, so we're moving along. Go ahead.
I just had a question. What did you say this patient was also a smoker? Because why are the bronchial walls so thick? I didn't know that Ritalin itself could cause that bronchial wall thickening.
I don't have a good explanation, but you know, I don't know what other bad habits the person had. I don't know about cigarette smoking, and you know, perhaps with drug use and stuff, there had been aspiration, and there could be some bronchial wall thickening on the basis of that, or
Okay.
things like that. So these people may have messy lives in other ways. Okay.
Yep.
Then this is an unfortunate 14-year-old who jumped into a lake, I think during a birthday party or something for his friends, and he was not a swimmer, and he disappeared from view. He tried to hang on to a friend and clear it, but he slipped off, and this guy was in the water for 35 minutes, stuff like that, before he was pulled out, and a resuscitation was attempted. He arrived at the hospital. He was hypothermic and had respiratory distress, had this chest radiograph, was treated with this ECLS here, or ECMO, to try to get some circulation going. So he did not survive, and he had this radiograph. He's got some debris here in his stomach, and in trying to suction this guy out, they recovered a lot of gravel, and they recovered gravel too from his GI tract down here. So this was part of the lake bed. You can see some small particles of probably gravel here in his lungs. So I'm showing you this case because I showed another case a few weeks ago of sand aspiration in a Hawaiian surf, where somebody was rolled in the waves and aspirated a bunch of sand. It was very bright, forming bright bronchograms on CT imaging. Here's this man's or this boy's CT scan. He's got this intense bronchiolitis. He developed a lot of pulmonary infections from this water exposure. So here's a case of dramatic bronchiolitis, tree and bud. And if we look at soft tissue window, you can see that there's this high attenuation material here that probably corresponds to the gravel that they suctioned out of him. So it's on both sides. And then we get down to the abdomen. Here's that gravel deposit in his stomach. So this fellow succumbed to respiratory infections and hypoxemia and multi-organ failure and brain damage from this drowning episode. So he was fished out, resuscitated. They got a heartbeat going and stuff like that, but he did not survive. So gravel in the lung here from that. And then here's an older man who has this lung consolidation here, had infectious symptoms. I thought this was going to be a bacterial pneumonia, Klebsiella pneumonia, given that he's got bad COPD. He's got tremendous emphysema on both sides with an upper lobe pneumonia like this. And this guy was CT'd, and here is his CT scan. So bad emphysema here, bullae in the apices, and then this dense consolidation here, and some components that look a little bit like, first time I saw this, I thought, is this necrotic lung here, or is this perhaps a mycetoma in a cavity here, or is it just some spared lung here in the middle of all of these bullae? And the organism in this case was kind of a surprise. This was a kind of mucor. This was called rhizomucor pusillus or pusillus, So this was a fungal infection, and this man's exposure was in his yard, or I don't know whether he works on a ranch or a farm. I think he has goats, and he had some hay, and the hay was covered with a tarp, but the hay got wet, and he describes pulling back the tarp and seeing all this black fluid and black stuff on the hay, and he just decided to cover it back up, so he put the tarp back down over it. But he did inhale stuff from that exposure, and that was it's probably moldy hay that created this fungal infection on him. So this man was not known to be immune compromised. He's not on steroids. He doesn't like doctors. He's not had a transplant. So, you know, he is obviously a cigarette smoker. It turns out that risk factors for mucor infection include things like diabetes. He's not diabetic. Malnutrition, and he was cachectic. He's got almost no body wall fat here, no mediastinal fat. And he has a microcytic anemia that goes along with malnutrition, so he's not been eating that well. He has some recent weight loss of maybe 10 pounds over 4 months. I was also suspicious this could be an adenocarcinoma of his lung here with his consolidation, given his smoking and emaciation. But this was all just mucor. So his risk factors include COPD, which is a risk factor for mucor, and his malnutrition. So that's probably how he got it, plus an overwhelming exposure from that moldy hay. So fungal infection here, in this case, mucor, but not the usual clinical context for the mucor that we see around here, which is bone marrow transplantation. Okay, those are my cases.
Thank you. That's great. Seth, are you ready to show a few?
Sure.
Okay. There you go.
There we go. Okay. So I have 4 cases. This one is just interesting that we just had the other day. Let me get this out of the way, this little GoToMeeting thing. So this is a adult patient with uncorrected tetralogy. And you can see here that this overriding aorta, this is actually the RV over here. It's quite hypertrophied, as you see in TETs. But this pronounced overriding aorta, here's a 4D flow image showing, interestingly, that here's left ventricle going to LVOT. You can actually see the regurgitation is actually directed towards the right ventricle from the aorta. And there's this very dysplastic pulmonary valve. And the reason this person probably has been able to, so here's the RV, here's this RVOT with this very dysplastic valve. The reason that this patient's probably been able to do so well for so long is because of the stenotic pulmonary valve. It's open, it's not completely atretic, it's stenotic, so it's increasing the pulmonary pressures, or at least the right ventricular pressures, enough that there's preferential flow through the into the aorta, not through the pulmonary arteries. There's enough flow in the pulmonary arteries to kind of supply it and supply them with oxygen, but enough going through the systemic circulation to, so he wasn't that symptomatic. And then here's just another couple pretty images from the 4D flow showing this. I think I already showed this one. Let's see, here's another one showing the VSD. And then, so they got so there's a little bit of flow across the VSD. Again, this big overriding aorta, right ventricular hypertrophy. Then they decided to get a CT on him because they were concerned about MAPGAs, which these major aorticopulmonary collateral arteries, which I thought was kind of interesting given the fact that he wasn't complete atresia. He's just a very stenotic pulmonary valve. I didn't think he would have MAPGAs. Here you can see this RVOT and this very stenotic little dysplastic pulmonary valve that was doming. We have some cine images, which I didn't include here, but you can sure enough see from the ascending aorta, there is this little major aorticopulmonary collateral going into the left hilum, supplying the left lower lobe PA, and then this MAPGA from the right here, from the descending going into the right PA. So just an uncorrected TET in an older patient, but some nice 4D flow images and nice CT imaging on that. And he's going to undergo surgery. And this is for Travis because we were talking about this the other day, about high origins of the right coronary artery. So barely included on the study, but we were, saying that the high origins often arise superior to what would be kind of the left aspect of the, almost over the left cusp, which this one does. You can see they often have this very medialized origin, and they course inferiorly, and they, again, course technically between the aorta and the PA, but this is not considered a malignant course. There's no real there's no intramural portion. This is not coursing in the wall of the aorta, and you can kind of see it always coursing inferiorly between the aorta and the PA before taking its normal course in the AV groove. So that was just not that interesting of a case, but a nice example of it, a nice kind of classic appearance of how it kind of travels.
Yeah, that looked identical to the one I had on MR with that medial orientation when it arises above the junction.
Yeah, and I have another one that I just happened to come across the other day. It's exactly the same. And in all the ones I've seen before, they really do have this medialized course. Why that is, I'm just not really sure. This isn't, and I'm sure I know people have shown this in the past. I just thought this was interesting. There's a lot of pulmonary hypertension here, and this was a PE study for a patient. They were looking for CTAP. She didn't have CTAP. She has primary pulmonary hypertension, or at least pulmonary arterial hypertension of some unknown cause, and which is technically all pulmonary arterial hypertension. Anyways, you can see this massive PA, the big RV. But what's interesting is you can see also all these collaterals from phrenic vessels coursing here. This is a phrenic vessel coursing into the hilum. Additionally, what was interesting to me, which I don't think I've seen before, she has this it's not the best image, but she has this SA nodal branch. And you can also follow this SA nodal branch out that provides collaterals to the systemic circulation to supply the lungs. And additionally, she has all the classic kind of intercostal and bronchial arteries as well. And then she had internal mammaries as well, kind of feeding the pulmonary circulation. So it's just a nice example. And also these very kind of pronounced kind of, I don't know if you want to call them ground glass, but this kind of blushing, this ground glass centered around the vasculature of the pulmonary arteries. And, some people say it's these cholesterol granulomas, other people say it's other things, but again, a very kind of classic picture for pulmonary hypertension, especially pulmonary arterial hypertension with his lungs looking like that. But it was just nice showing all these different systemic vessels kind of feeding the pulmonary circulation. In this case, a bad PAH. And can't remember what this case was. Oh, this was a young kid who came in with a cough and shortness of breath, has this very large mediastinal mass, and he underwent treatment for it. And what was interesting is, so a couple things. So he underwent treatment for it. He had this kind of ugly mass, and this was biopsied and was shown to be a yolk sac tumor, which is fine. And here's his AFPs, and you can see that the AFP started out extraordinarily high, and then as he had undergone treatment, which included pretty much chemotherapy, that the AFP went down to almost nothing, basically normal levels, and then they resected the lesion. And what was interesting is that after they resected it, they basically said it was a mature teratoma, which is not what it was. I mean, it was a yolk sac tumor, but what was interesting is that the chemotherapy killed, a lot of these tumors are mixed germ cell tumors, and the chemotherapy killed the yolk sac portion of it, but left the kind of benign teratoma intact. So, again, a lot of these germ cell tumors are mixed. So it's just interesting to see that. And they did mention there was a lot of necrosis and treatment-related effects, but it was just interesting to see in the pathology that all they saw left viable was basically benign teratoma, because the chemo had done the job killing the yolk sac tumor when they finally took it out. So I just thought that was kind of an interesting, it makes sense due to cellular turnover and rates of replication, but it just was an interesting case. So,
so once it responds to chemo, do they go in and then take it out?
That's exactly what they did. So once so once they treated him for a while, that they were following the FPs, was shrinking down, and they just took it out. Once it got down to a point where it was still a large lesion before they took it out. I think this is actually the pre, and then this one was the post. So it still was a big mass by the time they took it out. But by the time they took it out, it was just
teratomatous.
Just teratoma.
Cool.
It wasn't even malignant teratoma. It was just teratoma. But they had big chunks of it from an outside institution when they did the initial biopsy before treatment, and it was yolk sac tumor. Well, they called it mixed germ cell tumor, yolk sac predominant.
Yeah.
But those are my cases.
Great. Yeah, those are interesting.
Howard, I'm ready if you want to let me show a few here.
There you go, Travis.
Okay, do you see a CT?
Yep.
Yes.
So this is one that my colleague Kim Calianos shared with me the other day. And I'm going to show you kind of in reverse chronological order, because when I saw this, I mean, this is something I've never seen before, this manifestation. But so she showed me this, and you can see that the trachea has a bunch of little tiny nodules. And at least up top, you think they're mostly along the anterior portion, so maybe some tracheobronchopathy, osteochondroplastica. But then you see that there's some involvement of the posterior membrane as well, which kind of throws that out. This lady's 58, and then so quickly going through my mind was like papillomatosis, and then you look at the lungs, and her lungs, I don't know, this is a little bit of scar. Now, there's nothing really that screams papillomas in her lung at this time, but interestingly, she has had a prior right lower lobectomy. So before I show you what it was before and what this is, anybody have any guesses?
That this is not papilloma?
Correct.
Amyloid.
It's actually a neoplasm. Amyloid, I think, is a good guess. And if you go back, here's 2009, and she presented with right lower lobe atelectasis and had this enhancing endobronchial tumor here, which was a carcinoid tumor. And what's interesting at the time, and she had this weird look, I don't know if this is some ex vacuo pneumothorax there, but the rest of her airway was fine. And they went in and took out this carcinoid, and this turns out to be carcinoid that has disseminated through the tracheobronchial tree. And this is another study in 2014, and you can see she had some larger polypoid lesions. She actually had to have one that was laser excised off of her true vocal fold as well. So I have never seen this as a manifestation of carcinoid, but these are all carcinoid tumors through her airway that have been treated with like laser excision and just reduction.
That's interesting. Did they, before they took it out, when they first made the diagnosis, did they go in there and biopsy the heck out of this? And
I don't know. This was all done elsewhere. This is the first time she's actually come to us and all these other ones were outside studies, but I don't know. But this is, it
was a low-grade carcinoid, or was
I think it was just like a typical carcinoid. I don't know. I'll have to pull up the path and see if I can find it. But I just thought this was fascinating that it just extended through the airways proximally.
So, Seth, do you think the procedure might have just sort of scraped the lumen and sort of inoculated the surfaces? And
yeah, I was just thinking, how does a relatively low-grade malignancy, neoplasm, disseminate like that? And I was just thinking maybe they macerated the tumor during treatment, and somehow little tumor cells dropped. I don't know.
Right.
Whenever Howard shows his cases, I'll look again at the path and just see if I can dig it out of the chart. But I just thought this was cool because I'd never seen this before.
No, I've definitely
that was really
never encountered anything like that.
Yeah. So we proposed a couple of different names for it, including instead of dip niche, but dit niche. So diffuse idiopathic tracheal neuroendocrine cell hyperplasia. But I don't know. This is weird.
Very strange.
Okay.
Very strange.
Now, this is one that I was talking to Seth about the other day, and it's pretty cool. And if Brent is on there, and if Art is on there too in the background, who I heard. So this is a 5-month-old. So it's an old case, but I just came across this because it was discussed at our congenital cardiac conference. It's a 5-month-old that's already had, I guess he must have had a coarct. I don't know, because that doesn't look like it's a PDA stent. Or actually, maybe it is. No, never mind. It looks like it is a PDA stent. But anyway, he had some issues at birth, and one of the issues you can see here, his aortic valve. You can kind of hallucinate that it's a little thickened. But anyway, he had congenital aortic stenosis and had heart failure. And I don't even know why they were doing this study, but it's a relatively delayed venous phase. And you can see this marked circumferential, millimeter thick band of low attenuation throughout the entirety of his left ventricular endocardial surface. And so this is, I think, the second case of this I've seen. The only one that's path proven, and the other one we had was on MR, where there was typical delayed enhancement, subendocardial diffuse, not in a vascular territory. So this is a fairly rare entity, but it's endomyocardial fibrosis or fibroelastosis. So it's endocardial fibroelastosis. And they actually went in and did surgery with him and stripped this. So the valve is kind of thickened. This is a non-gated study, but you can still kind of see the valve. So it was this fibromyxomatous valve, and then he had some left ventricular dysfunction. And so they go in and they actually peel this off. So it's this, and they called it fibroelastosis, but that's a typo there. But yeah, so this is typical, 1 to 2 millimeters thick. It's like this glistening white tan stuff that develops, and it's often seen in patients who just have increased strain during development on the left ventricle. So aortic stenosis is a typical cause of it. But this is the prettiest case I have, especially because we actually have path on it after this. So I don't know if anybody else has seen one of these. I think, Seth, you said you didn't have a path proven case, did you?
No, and it's amazing because I've seen not a fair amount of congenital aortic stenosis and stuff, and I just have not seen it. It's remarkably impressive.
Yeah. So this wouldn't occur in an adult then. This goes with congenital condition, not with adult aortic stenosis then.
Correct. And and you, of course, you get endomyocardial fibrosis in patients with like hypereosinophilia and Loeffler's, which I think is probably similar from a pathologic standpoint and an imaging standpoint, but yeah, mechanistically is different. So in terms of the way it develops. So that's a path-proven case of endocardial fibroelastosis. And I think, Howard, I'm going to show 3 quick ones in succession, if that's okay with you.
Sure.
I was in Chicago last week, and we were talking about some things that people never see. And one of those, one person was making a comment they never see is this, or have rarely seen. And, oh, come on. Let's see if I can do that. And then I came back, and we've had 2 cases of it recently, just that had been accumulating over the course of the last couple of weeks while I was gone. So you can see 2015, 2017, the patient's obviously intubated now, came in unstable. But of course, the finding is in the aortic arch. So we have nice calcification here. And now we have this extra opacity along the aortic arch and this displaced intimal calcification. And so this was a patient who came in. It's not really a diagnostic dilemma, but here you can see this was from an acute type A dissection, and you can see the displacement of the calcification in this case. So I know we've shown a couple of these. It is a pretty rare presentation, but it's the thing we always look for on radiographs, but don't usually see such a nice example where we at least have priors to compare to.
Yeah.
So I'm not going to belabor the point of the dissection in his case, because it's not really, that's not really all that important. The next one, though, is kind of a cool one, because both of these radiographs are kind of interesting. So this was a radiograph in 2007, and then she comes back in 2017, and there's 2 things here. So if you look at give you a second to look at them, and of course on the more recent one, you can see here that she also has this kind of extra opacity over the aortic arch that wasn't there before, as you can see. But also up higher, you can see that back then she had tracheal deviation and this
the cervicothoracic sign from this big mass. So in the interim, she had this big goiter removed, but then developed a chronic type B dissection and was lost to follow-up. And this is just a big aneurysm and type B dissection that you can see here. I also like this. I'm glad Seth is on, because this is one of those ones that causes controversy, because the dissection looks like it extends, well, it does extend into her, arch vessels. You can see here into her left carotid. And of course, people want to call this a type A dissection, but as, and actually I did have one question, Seth, what you think of this? Because as Seth has made the point, and as they wrote in Radiology, their Maryland group, that, just because it involves the arch does not make it a type A, that it needs to involve the ascending aorta. But then you've got this funky flap right here. So I don't know if that would be enough for you to call it or not. I mean, clearly it mechanistically looks like a type B.
Well, where's that? Where's the? Yeah, it would be just where that level of that rent is in the, because I think that is an intimal injury in the.
Yeah, let me see.
Or is it a? Well, is it a fold? Jeez, yeah, these.
Yeah, I know. Well, because it's one of those ones that it's. I don't know if it's just a fold right there. It's right here.
God, I don't even know. Like, you would assume it probably probably related to the dissection, given the fact they have a dissection. But
yeah,
and
I know. So anyway, she underwent repair today, but it was more the sequential radiographs showing the differences. I thought it was nice having the thyroid there as well.
Travis,
what was the point of
the repair? Yeah. Did the repair consist of ascending aortic repair, or?
I don't know. I just saw post-op radiograph on her this morning, so I haven't. I mean, because her ascending aorta, at least, from the just proximal to her arch, looks fine. So I don't know. I'll look and follow up. But yeah, I don't know if this is.
That undersurface of that ascending aorta looks kind of baggy to me. I don't think that's a normal ascending aorta.
Yeah. No, I think it's all aneurysmal, and whether this is an actual intimal flap or whether it's just a fold because it's a big redundant aorta, I don't know. But I'll look and see.
There's not an earlier CT from the era of that goiter, is there?
No, unfortunately not.
And you don't think that the type B dissection arose because of her thyroid surgery? I
doubt it. I looked at the notes. It was a couple years later when she was hypertensive and found to have a dissection outside hospital and then lost to follow-up and then came back here. But yeah, Seth, I think this is one of those ones that really pushes the boundaries of the classification.
Yeah.
All right, and then the last one is kind of cute too. This one here, we had a run of dissections. This one, the radiograph isn't really helpful at all. And maybe you say that she's got some left ventricular hypertrophy. But what was cool about this was just the distribution of the dissection. And you can see that she has a big fenestration in the ascending aorta, we're not in an unusual location. But if you look, what was interesting is it extends down the root, but she has hemopericardium, but she also has blood along the right AV groove. And it kind of narrows to a portion. They actually thought it was narrowing the right ventricular outflow tract when they did their echo. And this is all just hematoma around the right coronary artery, which I thought, and you can see it here, there's a little bit of stranding and inflammation of the fat, and clearly hemopericardium. I just thought it was an interesting distribution of blood, and she did have hemopericardium when they took her to the operating room, but all of this stuff.
That epicardial hematoma, for some reason, tends to mirror the RCA and that AV groove. I don't know why the cases I've seen have all been in that one location. I don't know why.
Because if you just, of course, that's not what this is, because you clearly have a dissection, but if you just saw this image, angiosarc or lymphoma or something weird.
Yeah.
Yeah. So you've seen that before, Seth, this kind of distribution of?
Yeah, I've seen it from a dissection. I also saw it from a patient with after TAVI developed this fistula and this big mass of hemopericardium that then dissected, well, to use a better word, dissected into the epicardial fat and then followed the whole RCA.
Yeah. Cool. So.
Yeah.
All right. So yeah, those are my cases for today.
Great. Yeah, I've never seen a hematoma in that location doing that to the RCA. That's my first too. Wow. Very impressive. Okay. I'll show a few. Well, I was going to try and hide some of these. Well, actually, no, that's fine. I've hidden the diagnosis. Let me show you. First, just a really nice example of a thing we've all seen before, but this one's really a pretty one. So this is the chest radiograph, and it's a very nice teaching case. So I'll give you a moment to look at that. So a very nice demonstration of rib notching. Pretty conspicuous here on the undersurface of these ribs. And they're a little bit hard to describe, but the aortic arch doesn't look normal. It doesn't have the normal appearance of an aortic arch. And there are interfaces here where the aortic arch is, but they appear a bit unusual. So this isn't, to my eye at least, a typical 3 sign per se, but this does look a little bit narrow. It looks a little bit odd. And yes.
Do you have a lateral view? Howard, is there a lateral?
Sure.
So when I was at Duke in the old days, there was a very skillful cardiac radiologist who relied on chest radiographs and fluoroscopy. One of the things he pointed out with aortic coarctation is that if you look on the lateral view behind the trachea, you normally see the top of the aortic arch. And if there's coarctation, the aorta is atretic, it's small, and it's pulled into the mediastinum, and you don't see the arch posterior to the trachea. And I think that your case follows that rule here. You don't see the top of the arch behind the trachea.
Here. That's an astute observation. Wow. But I think you're right. At least we don't perceive it as such coming down right here, right? Ice?
Usually you see the top, the horizontal part as it the top of the arch, and it's gone here.
Right. So actually, with that observation, I'll be happy to show the sagittal, and let's see if we take a look at that and look at the configuration of the arch and the degree of narrowing of the aorta here. It's relatively small, severe coarctation there, and all the collateral vessels that one expects to see. There's also a bicuspid aortic valve, so that goes along with that combination very nicely as well. So there's your bicuspid valve. So just a really nice teaching case. Well, that's a great observation. That's pretty subtle. If someone made that observation, putting the things together, that's pretty good. I like that. I like that. Okay. This is kind of an everyday, but it's such a beautiful case. I'll show it to you. So when I read this chest imaging exam, we had the usual history of, I think it was shortness of breath or chest pain. I can't quite remember. I did describe some subsegmental sized ill-defined opacities in the right middle lobe and left it at that. And as you can see a little bit later on the same day, a couple of hours, the CT-PA was done. And yes, that opacity in the right middle lobe has features absolutely typical of an area of pulmonary hemorrhage. We don't know whether there's some infarction within, but otherwise a non-enhancing opacity consistent with pulmonary hemorrhage. And let me just bring the MIPS, because this was a case in which if I saved the MIPS that I made, one can see a vessel. Maybe I didn't. Let's see if I did. You can actually see the absence of the vessel. So let me just mag this one up and show you that right middle lobe pulmonary artery here. And just beyond this point, as in right there, it becomes a gray sausage rather than a white one. And you can actually see distension of that pulmonary artery with embolus. And you can actually follow the non-opacifying vessel right into there. So let me make that just for fun a MIP so that we can see that a little bit better, just for fun, and see that embolus in that location. So there's the embolus there, and the non-opacified vessel just goes right into that area of pulmonary hemorrhage. There are emboli elsewhere, but I thought that was a really nice teaching case of pulmonary embolism with focal pulmonary hemorrhage.
So people still talk about Hampton's hump.
Yeah, I wouldn't call that a Hampton's hump at this point. It's not necessarily an infarct. It may resolve entirely, but it's a focal opacity. This is a case I know Travis will like. It's a case of aortic pseudoaneurysm. So the context here is a person with a history of IV drug abuse, endocarditis, aortic valve replacement. So there is your aortic valve. I can't quite remember the timing of it, but these pseudoaneurysms are pretty impressive. So here we are at the level of the aortic prosthesis. This whole thing, all that thing should not be there. And there is a second one right down here. So there are two pseudoaneurysms in relation to the aortic root, thought to be a consequence of infection. And I was pretty impressed by that. There is the normal looking left coronary artery, but a really impressive pseudoaneurysm. And they fixed that, and it was quite the operation. But they ended up putting in a Valsalva graft and a new aortic valve to fix that, and resected those pseudoaneurysms away from there. So pretty impressive pseudoaneurysms of the aortic root.
Yeah, and the lower one at least
Sorry?
involves the. Yeah, if you go down to the lower one, it's a good illustration of involvement of the mitral aortic intervalvular fibrosa. Keep going down to the root. So that portion right in there, that's kind of like the avascular portion of the aortic root, in between the aortic valve and the mitral valve.
Down here?
Yeah, so that area, because that's where it's most susceptible at the root, because it's relatively avascular.
They did actually mention something in the op report about that area. Let me see if I can find that.
Yeah, so it's the mitral aortic intervalvular fibrosa, or the mitral aortic curtain. I think there are probably other terms too. And I think there was actually, wasn't there a recent radiographics paper that talks all about the fibrous structure of the heart and goes into good detail on that area?
I'd have to look at that. I think I did notice that, and that was an amazing article with amazing detail of things I'd never heard of before. But basically, this so-called aortomitral curtain area, or...
Yep. Yeah, same thing.
Okay. And that's right down where I'm indicating here. So down in this area.
Sure, it's kind of like that anterior leaflet of the mitral valve, and then just inferior to the left and the non-coronary cusps, where you have that fibrous continuity of the two. So more anterior to where your mouse pointer is, like right along that anterior mitral valve leaflet.
No, that's posterior.
Yeah. Right where you're showing that hole right there, just between that contrast that's insinuating between the left atrium and the LV outflow tract. Right on that image. Yeah, right in there.
Right in here.
Yeah.
Okay.
And then as you scroll up, all of that area, yeah, that's where it's susceptible to pseudoaneurysm and infection.
Do you think a sagittal view is good to show that? Is this must be a sort of elongated structure up and down?
Yeah, and it kind of creates that double left atrium look, where it almost looks like there's a second left atrium behind the aorta, where you have that big pseudoaneurysm.
Right in here.
Yeah, that's a good view. Yeah.
Yeah, I think it's the biggest one I've seen in that location, if I remember correctly. All right, I think in the interest of time, we'll stop there this week. I have one more, but I'll save that for another time.
Really quick.
Howard, I want to show something real quick. Howard, show just a
Sure.
real quick show me.
Let me get my control panel here a second. Which is, hold on, sorry, hit the wrong button. There you go. I can see your images, but I don't hear you.
Somehow, but maybe not. Who knows? But anyways, this is the TAVR case I was talking about, where there was rupture of the root at the TAVR, and there's this fistula. But you can see this whole hematoma surrounding the
I see.
right atrioventricular groove, and you can actually see here. This is all hematoma surrounding the whole course of the RCA, and it's on the epicardial fat. This is deep to the pericardium. They sucked out the blood out of or a lot of the blood out of the pericardium, and it was interesting. And the surgeon said he'd never seen anything like it. It was like he lifted up the heart, and the whole heart looked like someone had beaten on it like a punching bag. It was just all bloodied and bruised. So this is another case of that hematoma in the AV groove. And I have one other case from a dissection as well. But anyways.
Excellent. Wow. All right. Thank you, everyone.
Thanks, guys. All right. Take care.
Thanks, everyone. Same time.
Thanks. Bye.
Bye, everyone.
Right.